Welcome to Heart Nurses, brought to you by the Preventive Cardiovascular Nurses Association. PCNA's mission is to promote nurses as leaders in cardiovascular disease prevention and management.
I'd like to welcome our audience today where we're speaking with Mary Nejedly. Mary, could you introduce yourself, please?
Mary Nejedly. I've been a nurse for over 40 years and a nurse practitioner for over 30. I currently have been working at Stanford Healthcare. I started the Women's Heart Health Program 17 years ago with Dr. Jennifer Tremmel, and I have also been a big proponent in the prevention clinic as well as general cardiology. I've also been a lead APP for 7-8 years. It's hard to remember. So here I am.
Well, Mary, thank you so very much for joining us at the table today. I'm sure our audience recognizes the expertise you bring and that you have to share, particularly on the topics that are most interest to you and that you really want to share about. And that first piece is about women's heart health. Would you like to tell us a little bit more about that?
Back in the day, Dr. Tremmel approached me and asked, because we did not have a women's heart health program, and she was tasked with starting this program. So she asked, how could we do this? I was a new NP, I was a NP at Stanford, not new, but new to back to Stanford. I'd been a nurse there before. And we were brainstorming on how could we start this program. And it started with, well, they're nurses, predominantly female, should we start there? But it all branched into, we started this Employees Get Healthy program.
Wow.
So how could we outreach? We thought we'd do this. We worked with the university's health program, because actually back then, Stanford did not have an employee health program. So we did this pilot project. In fact, I even spoke at one of the nursing seminars about our program, that we got people to take this health survey, but it was all employees. I got physicians on board to kind of say what they did for their health. And it just turned into this pilot project of Employees Get Healthy. And so when I went to occupational medicine to say, you know, how in HR, how do we, they said, oh, we don't have money for that. So I was going to write a grant to get this employee service. And then all of a sudden the government says every employer has to have an employee wellness program. And then it was like they used all our groundbreaking stuff that we did for the Women's Heart Health Program to start the Employees Get Healthy program. And it's now called Healthy Steps.
That's just an amazing story of really, if you will, kind of scrappy beginnings in terms of knowing what needed to be done, being willing to put in the effort for that grant application that then just kind of, the whole process just bloomed and blossomed and has continued now all these years later.
Yes, yes.
What's your favorite part about that particular program? Do you have one? I know all of it's very important and great, but do you have a favorite?
What we utilized were health champions. So we went, and they still, I think, utilize health champions. So every department, I found someone in the echo lab, I found someone in the cath lab to help engage their fellow employees to take this wellness survey and find out what they needed or didn't need to promote their own health. Because we should start with ourselves before we start promoting other people's health.
So have you seen much in the way of change when it comes to like clinical practice or even interactions in the EP lab? Has anybody shared with you that by doing this activity, I now understand, I recognize, and I can share more effectively with my patients?
Well, this has been, no. I mean, to tell you the truth, once Employee Health took it over, I just see what they've done. Gotcha. And they do the wellness things, and they do the healthy steps, and then you get other things, but I haven't actually, as it grew through the whole hospital, I have not been able to follow up because my role grew over the process. So, but I think people do take on that they need to take care of themselves. And that's the whole thing of prevention. It's the groundwork for anything that we do.
So let's talk a little bit more about that. That prevention really is that bottom layer in terms of overall health. Now, we all know that we cannot change our genetics. There are some circumstances that have happened in the past that we can't change in terms of exposure to perhaps any toxins or things like that, that just, you can't go back in time. Unfortunately, some of us that are a little bit older are both grateful and sad about that whole process. But talk a little bit more about that prevention piece.
Well, you can't change your genetics, but you can change what you do to add to them. It used to be, genetics is the gun, your environment's what loads the gun. I don't even like using that anymore. What I like to say is, you do what you can do. You do what you have control over. And they had Life's Simple 7, now it's Life's Essential 8. There's everything that you could know how you can help yourself. And then, you talk about genetics. Well, we now have polygenic risk scores, and they looked at these polygenic risk scores. And if you looked, and it was at Life Simple 7, and if you optimized Life Simple 7, even if you had a high polygenic risk score for cardiovascular disease, you could add, I think it's 12 to 15 years of life disease-free by optimizing what you have in your own hands, what you can do for yourself. So I thought that was at the PCNA conference I went to 2 years ago when they talked about the polygenic risk score and comparing it to Life Simple 7. And to me, I went and did a community talk, and I couldn't wait to tell people about that. So no, you can't outdo your genetics, but yes, you can.
Yeah.
So
you can't change it, but you can almost outsmart it, if that makes sense.
Exactly. You have a lot in your own control. And that's why I wanted to always talk that, it's not a given, and, you can't do anything, so you're going to smoke because life, your parents died young.
Yeah. So I hear such hope, such enthusiasm, such passion about what you do every single day. And in that prevention arm, and particularly for our patients who are trying hard to make changes in their life. There are things that happen along the way where they might be, for example, working on healthy eating, and then something happens to trip them up. But it's really never too late to continue that. So even though I might have, if you will, lost myself at breakfast and now realized that those were not healthy choices that I had, there's always the next meal. So I think part of what you do probably every day is to, encourage people along that prevention pathway.
Oh yeah. And then seeing people, and especially when you're first seeing them, they have a lot of things to work on. And so that's where you get into that shared decision making, and you just say, okay, let me just put them out there, but it can feel overwhelming. You pick what you think you can do, and we're going to work on that. And then I don't overwhelm them with saying, do this, do this, do this. Obviously, if they need medications, I have to do that. But then I let them pick, and I still think of this one overweight African-American woman, very intelligent, but she was still smoking. But I wasn't going to tell her that if I had to choose, that's what I would choose. She wasn't there yet. I would have tell her, I don't want you to smoke. And I have to tell her, that's my job, I have to tell you that. But I'm going to let you pick, whether it's exercise, changing your diet, maybe 1 or 2 things in your diet, quit drinking juice or something else. But when you get them engaged, because you don't want to, they talk about this, I don't want people to be a flight risk. Never come back to my clinic, never see them again. I want them to make their follow-up appointments so I know that I will see them in 3 months or 6 weeks, whatever we make as the follow-up, depending on what other things were going on. I don't want a flight risk. I want them to come back so I still have another opportunity to engage with them.
We've been talking with Mary Nejedly about prevention, and we are going to take a quick break.
For more education, resources, and tools for your clinical practice, visit pcna.net. You'll find CE courses, patient handouts, and more, all free to access. Visit pcna.net.
We are back speaking with Mary Nejedly. And Mary, let's pivot a little bit and talk about community outreach.
So my big bugaboo or thing is that we need to do more bringing the community and doing talks at their level for people to understand what's in their hands, just like we talked. Recently, I bought into a 55 plus community, and I was asked to speak a few times, and I did just a general lifestyle and exercise that you have in your hands that you can live longer with. And they even had another speaker who said, younger next year, and what you need to do to be younger next year and live a very productive life into your 80s and 90s. And so I just think that is where we have an opportunity to educate people who, I worked at Stanford. I think the community around there is very well educated, but people are coming from all walks of life into this community. Never heard before that gestational diabetes or preeclampsia affects their future risk for cardiovascular disease. We all know not to smoke and exercise is important, but this woman came up to me and she said, I never heard that before. She goes, with both pregnancies, I had preeclampsia. No one ever told me that. Another woman came up, I have autoimmune disease. No one told me that I have increased risk because of my autoimmune disease. Just to be aware of what your cardiovascular risk is, and we need to grab people young so that not 6 months after they had a baby and everything, let them calm down, but just know that your risk is elevated. Doesn't mean it's gonna happen, but that you're aware you should exercise, watch your weight, eat well. And then monitor your blood pressure, monitor your diabetes or blood sugar. So it's just, I think we have a great opportunity to reach out to the community as much as we can and do these talks.
It sounds like from both what we talked about before the break and after the break, what we're really trying to have happen is multiple touch points and multiple perhaps healthcare professionals or community members that are involved in this conversation. So it's not a one-time, oh yeah, I heard somebody talk about that way back, 3 years ago and haven't done anything about it. Mm-hmm. Or, one of my healthcare professionals talked about it, last month, and then I forgot about it. So having that ongoing conversation and that ongoing, if you will, empowerment for patients that they can, as you say, take things into their own hands. They can make a difference, no matter what has happened in the past. It's still something that they have in their power. And I think for most patients, that's really a big difference, because a lot of times they feel like they can't make any choices or differences.
And I love that we have Heart Month. I mean, Women's Heart Health with the Go Red for Women campaign. When that started in 2000, that's when we saw the decrease in women. So awareness, breast cancer is not your biggest risk, it's heart disease. A lot of women still don't internalize that to themselves. So I just think we need these constant reminders throughout the year, and then going or having it in communities. It doesn't have to be in a 55 plus, it can be at the rec center, it can be at, Avenida's a senior center, but just that people are reaching out to other folks who might not get the same information from where they are being seen.
Mary, we are so grateful to you for taking time with us today. It has been so enlightening for us to hear from you about all these topics. This is Geraldine Warfield, your host, and we will see you next time.
Thank you for listening to Heart Nurses. We invite you to visit pcna.net for clinical resources, continuing education, and much more.